good morning all of you, esteemed dignitaries, invited faculties, resource persons, and all my dear students. Indeed, I am so happy, rather I am really delighted to be among you with such a novel concept of lecture series for the young generations, especially the resident doctors, the postgraduates. I congratulate the entire association of physical medicine and rehabilitation for evolving such a nice concept that you organize this lecture series at different places. And I am so happy that we have also given this opportunity to AIIMS Patna to organize this. And I congratulate Dr. Sanjay Pandey and his entire team for doing such a brilliant job. I had a hectic schedule actually, a series of this month, a really hectic series. And our institute day is coming up in a few days, and then we have the SFC. We have just completed our standing finance committee, the standing academic committee, the governing body and institute body. Though Sanjay had reminded me that I have a class today, I had really forgotten. Today morning my secretary informed me 6 o'clock, sir, you have class. And then after that I started preparing for the class. And but it was a pleasure. I always get the maximum happiness when I take a class because primarily I think I identify myself as a medical teacher. And in my classes I'll try to give whatever I have learned as a student and then as a teacher till now. So the topic is that the spinal injury, I speak from the physiological perspective and keeping in mind that for the physical medicine and rehabilitation, how the rehabilitation program are physiologically also based. So the spinal organization is, let just me give you some basic concept. I mean, you know it, but then I'll just make a review of it. You can see here the point. Okay, no problem. So you can see here the spinal organization, the motor cortex, and the brainstem, and the spinal cord. You can see here the spinal cord is at the center of the spinal organization. You have the cortex, you have the brainstem, they project to spinal cord. Then spinal cord has the motor neurons from where you have the output, the motor output that goes to the muscle, and then the effects. And from the muscle, when the muscle is being contracted or the muscle is in action, that time the sensory input from the muscle and from other body parts, they convey the input to the spinal cord, and the sensory information is conveyed to the thalamus, the motor cortex, and of course the sensory cortex, but then mainly to the sensory cortex, but then from there information also goes to the motor cortex. That is what is called the cortical sensory motor coordination. So spinal cord plays a big role. It is actually at the center of the organization of the neurophysiology of the sensation and movement. Okay, before again I go to the topic proper, I'll give you a very brief concept of control of posture and movement. The movements are planned in the cortex, basal ganglia and cerebellum, and the motor command. The command means after the planning is made, the command for action is conveyed to the spinal cord motor neurons, and then from cortex, directly inputs comes to the spinal cord by means of the corticospinal tract, and from basal ganglia and cerebellum. From basal ganglia by corticobulbar pathways, from cerebellum via the brainstem to the spinal cord, what is called the extrapyramidal system. So, extrapyramidal system projects from the brainstem to the spinal cord by the bulbospinal pathways. Again, this looks a little complex picture, but actually it was a much more complex picture. I have simplified it here. The motor areas in the brain, they project, the motor area directly project to the spinal cord, and this is the corticospinal tract. Then from the motor areas, there is also projection to brainstem, which receives input from cerebellum, and from basal ganglia through a loop, it receives input. So that is what is called the corticobulbar projection and cerebellobulbar projection. Then from the brainstem, it projects to spinal cord. That is called the bulbospinal pathway. So the motor cortex directly to the spinal cord via the corticospinal tract and via extrapyramidal systems, that is from the basal ganglia, from cerebellum, and also few inputs from the motor cortex to the brainstem and to the spinal cord. Then most crucial in this organization is this. The spinal cord is afferent and efferent. Here, the spinal cord that projects to the skeletal muscle via the motor neurons, and that is the output. And then the skeletal muscle gives input to the spinal cord, that is the afferent. And that loop of the output from the anterior horn cell to the muscle, and from muscle the sensory input to the spinal cord. That plays a critical role in the reflexes, the spinal reflexes, and also the integration of the sensory activities. The supraspinal inputs controlling the spinal motor neurons carry three important functions: initiation and execution of the voluntary activities, coordination and smoothing of the movement, and postural background for adjustment of the movement. So this is a gross schematic picture what I was telling you. When we thought of doing something, the plan is made in the higher cortex, the association cortex. That is the idea and the thought. Then it is conveyed to the basal ganglia and lateral cerebellum, where the planning is done in addition to the neocerebellum. And then the input is conveyed to the cortical motor areas, from where you have direct projection to the spinal cord, and via spinal cerebellum, and via the brainstem, that is all the corticobulbar projections, they come to the spinal cord. And then finally the muscles, which is the major output, for the motor activities. So the integration of the motor control, the mechanisms involved in the regulation of the posture and movement are integrated at the spinal cord, at the medulla, at the midbrain, at the cortex, at the basal ganglia and cerebellum. Today we are focused on the spinal cord. The influence of a particular center is studied, how different centers they are involved in regulation of posture, movement, and other activities. It is studied by separating that center from its higher center. And here the separation is done by that is what is called the transaction in the neuraxis, the cortex, the brainstem, the spinal cord. So if you are interested to study the function of one area, just transact it from the structure above it. Then you can study better the function of that area, because the higher influence is lost. And when a higher center is removed, immediately you see a release phenomenon which actually facilitates the final motor output. And this actually happens in the spinal injury. So what happens here? There will be facilitation that happens, as I was telling you, the release phenomenon resulting in facilitation. That happens by two mechanisms. One is the release of the center from its spinal centers or the higher centers. Usually the basic principle is that a higher center is usually inhibited. So when you make a transaction above a center, so the inhibition is lost, and therefore there is a release from the inhibition from the higher center. And not immediately, after a few days or even after months, there occurs denervation hypersensitivity. So this release phenomenon and denervation hypersensitivity contribute to the facilitation of the activities of the center. The postural reflexes are these reflexes maintain the balanced posture of the body. They provide a stable background for movement. They adjust body posture during movement. And these postural reflexes are of two categories: the dynamic reflexes and the static reflexes. And the reflexes integrated in the spinal cord are the stretch reflex, the myotatic, the inverse stretch reflex, that is the inverse myotatic reflex, withdrawal reflex, supporting reaction, both positive and negative. The spinal integration, the spinal cord subserves four important motor functions. It contains the neural circuitry for the spinal reflexes that produce immediate change in motor responses. It contains the neural circuitry that alters the motor neurons' output to maintain the tone of the muscle. It contains the neural circuitry for pattern generator for basic locomotion. And the tonic stretch reflex and supporting reactions executed in the spinal cord, they maintain the posture. As I was telling you, actually this is done in the experimental animal. Actually, many of the concepts of neurophysiology have evolved actually from the experimental neurophysiology. As I was telling you, if you are interested to study the function of one structure, you transect it from its higher center. Here it is called the spinal progression. The role of spinal cord in regulation of movement, posture, or even sensory function is studied in a spinal animal. In spinal animal, the influence of the brain on the spinal cord is studied by removing the influence of the brain on spinal cord by making a section just below the medulla. The medulla, then the spinal cord. So you make a section just above the spinal cord, that is medullospinal junction. And this is what is called the spinal injury. Three phases are distinctly observed in a spinal animal: the phase of shock, the stage of recovery, and the stage of failure. The stage of shock, immediately as soon as you make the section, immediately you see actually the animal enters into a stage of shock, and this is called the stage of flaccidity, during which all sensations, the voluntary movements, reflexes below the lesion are profoundly depressed or lost. The duration of shock depends on the degree of encephalization. That means how much the brain is developed in that species of the animal. If you do in frog, it is just for few minutes. In dogs, few hours. In monkeys, few days. And in human beings, it is few weeks. So this actually speaks the development of the brain, the cortex, and also the influence of the brain on the spinal cord. The mechanism of shock is that as the brain is disconnected from the spinal cord, the influences coming from the brain via the corticospinal tract, the extracorticospinal, the extrapyramidal tract, those descending tracts actually, they keep bombarding the anterior horn cells. So when this transaction is made, this immediately the cessation of this bombardment on the motor neuron from the higher cortical areas results in this shock. The features of shock, there will be flaccidity immediately. There will be total loss of tone. All the reflexes are abolished. Areflexia, anesthesia, bladder and rectums are totally paralyzed, and there will be gross hypotension. Then there will be recovery, that is called the reflex recoveries. The first to recover the reflexes, the reflex activities. But before that, the smooth muscles will be the first to recover. In that, the sphincter vesi is first to recover. detrusor muscles regains the tone slowly, blood vessels regain the tone, blood pressure comes back, but then it fluctuates for a few days before it normalizes to a some normal level. Reflex responses, the first reflex to appear will be the withdrawal reflex, because that is the protective reflex. So nature has given the mechanism to first this reflex to recover first. The stretch reflexes recover little later, but then once they recover, they become hyperactive. The mechanism of reflex recovery is that the loss of the neurons, because the transaction is made, so the neurons are degenerated. So the space occupied by the degenerated neuron from the new neurons, they sprout their terminals and they become more active, and that is what is called axonal sprouting. That actually is the cause of this reflex recovery. And then the muscle tone and the size, not only the tone reappears, the tone becomes more, that is what is called hypertonia. But first actually tone appears in the flexor muscles, as I told you, the withdrawal reflex. These are actually flexor reflex. Similarly, the tone appears first in the flexor group of muscles, and that is what is called paraplegia in flexion. And then after a few days, the tone appears more in the extensor muscles, and always the extensor muscle tone overtakes actually the tone of the flexor muscles, and then there will be paraplegia in extension. And this is a picture of, in the first phase, there is paraplegia in flexion, and then the paraplegia later in extension. So the mass reflex, this is another reflex, a very interesting reflex, the mass reflex, which is actually used by the clinicians for this mass reflex is used by the clinician actually in the spinal human being. That means a person whose spinal section is transected and he has lost the blood reflex and bowel reflex. So this one is used by the clinicians to stimulate the bladder and this bowel function. What is this? By scratching the lower part of the abdomen or pinching the inner part of the thigh, you get actually a widespread response, what is called the mass reflex. And this mass reflex is nothing but what actually happens. This results in flexor spasm of the lower extremities and contraction of the anterior abdominal wall. This results in evacuation of bowel and bladder and profuse sweating below the level of lesion. The spinal men are taught to evacuate the bladder and bowel by themselves activating this reflex. If they themselves also pinch the lower abdominal wall or they pinch the inner aspect of the thigh, that stimulates the bowel and bladder reflex and they evacuate the bowel and bladder. Then the autonomic reflexes, the mituration reflex becomes hyperactive. Bladder is never emptied completely because the hyperactive reflex keeps the bladder in a shrunken state, causes hypertrophy and fibrosis of the bladder wall. This is what is called the neurogenic spastic bladder, spastic neurogenic bladder. Defecation reflex regains, but rectum does not empty completely. BP remains normal at rest, but it has wide swinging once there is activation. The supporting reaction. This is another important reaction which is not seen physiologically, but in a spinal animal, what happens here? The stress reflex, as I told you, not only they become hyperactive, they become little peculiar. If you keep a spinal animal on the table and you just touch the feet of the animal, the sole of the foot of the animal, just to touch, then as you withdraw your examining finger, that limb extends. And then within few minutes, the limb becomes rigid. With the help of it, animal stands, animals even walks few steps. And just by touching the limb of the animal, there occurs extension of the limb, as if the limb is following the examining finger. Therefore, this is also called magnet reaction. This is called magnet reaction. And this actually, this supporting reaction is the proof that there is a center in the spinal cord, because you have already cut the structures above the spinal cord. So there is a center in the spinal cord. If appropriately stimulated, it stimulates actually a center which activates the reflex mechanisms, the tone of the muscle to assume the posture and assume some, the basic locomotion. This actually gives the concept that the spinal animal can be made to stand and walk, and this actually, and after some time it disappears. It does not stay for a long time. That is called the negative supporting reaction. So this actually gives you the concept that there is a locomotion generator in the spinal cord. The reflexes and muscle tone are not only they reappear, they become hyperactive, and the hyperactiveness is due to loss of the inhibitory influence, as I told you, the release phenomenon, and especially the increased gamma motor neuron activity, and the denervation, hypersensitivity, the axonal sprouting. And this is the anterior horn cell. These are the descending tracts, especially the vestibulospinal tract and reticulospinal tract. They keep combining this into the anterior horn cells, especially the anterior horn cell, which gives rise to the alpha motor neuron, and few cells will form the gamma motor neurons. This gamma motor neuron, which is connected to the muscle spindle, not the muscle spindle, this is responsible for the spindle sensitivity, and this controls the muscle tone. And this alpha motor neuron is mainly for the mediation of the reflex mechanism, and this actually is the primary mechanism which is responsible for hyperactivation of the tone and the muscle. Locomotion generator, this is what I was telling you. The spinal animals can stand, walk appropriately if stimulated, and they can assume the basic locomotion. This is what is called the central pattern generator of locomotion. And the evidences, as I told you, from the spinal preparation say that the spinal cord is activated by a mechanism, and there is a group of interneurons that actually constitute the central pattern generator for locomotion. CPG in the spinal cord is activated by the locomotor center in the midbrain. As I told you, though it is present in the spinal cord, it is not activated by itself. So it has to be activated. So this activation needs actually a drive from the hair center, and that is actually the mesencephalic locomotion generator. So what happens normally, the mesencephalic locomotion generator that is present in the midbrain, that is the midbrain locomotion generator, which is driven by the cortical motor areas. This drives the spinal cord locomotion generator, and this spinal cord locomotion generator provides the output signal for locomotion. And in spinal cord injury, this is lost. This is lost, and therefore this remains silent. But if it can be appropriately stimulated, the locomotion can happen, and that is what the concept of the spinal injury and the rehabilitation program, where you can, if you can appropriately stimulate, you can recover many things actually, not only the locomotion, the tone, and the reflexes. Then the sensory deficits, the features of the spinal cord lesion depends on the part of the spinal cord involved, and we see a lot of sensory problems that depends on which part of the spinal cord is involved. Diabetic syndrome, these are the few syndromes are described. Complete spinal sensory syndrome, Brown-Sequard syndrome, syringomyelic syndrome, posterior column syndrome, anterior spinal cord syndrome. This is the diabetic syndrome, where actually this is the posterior column and this is the dorsal column. So this is the posterior column, this is the dorsal column, and this is the anterior aspect. So here actually part of the dorsal column is damaged. That is this is seen in Davis dorsalis, therefore this is called diabetic syndrome. Then posterior column syndrome, the entire dorsal column is damaged, and this is hemisection of the spinal cord. One side of the spinal cord is transected in the spinal cord injury, and that results in Brown-Sequard syndrome, a complete transection. Then you have only the central part of the area surrounding the central canal is damaged. That is called it happens in syringomyelia, Therefore, this is called sphingomyelic syndrome. And if the anterior spinal artery is lesioned, or there is an obstruction, or there is bleeding, then this the anterior part of the spinal cord is affected. That is called anterior spinal cord syndrome. In this, the diabetic syndrome, there will be loss of sense of position and also vibration because the dorsal column one side is affected. Then complete spinal sensory syndrome, that there will be complete loss of sensations. All form of sensations are abolished below the level of lesion. Usually a narrow zone of hyperesthesia occurs at the upper margin of the anesthetic zone. And Brown-Sequard syndrome, this is very typical, where the hemisection of the spinal cord is made. On the spine of lesion, on the side of lesion, there will be fine touch sensation, proprioception. These sensations and the tactile discriminations are lost. But typically, on the opposite side, the pain and temperature sensations are lost. But on the same side, it will be just opposite. And in sphingomyelia, where actually the small part of the surrounding the central canal is damaged, there will be the lesion interrupt the lateral spinothalamic tract. Therefore, pain and temperature are lost without affecting touch and postural sensitivity, and this is what is called dissociated sensory loss. Posterior column syndrome, that is the dorsal column on both sides are lost. Therefore, there will be loss of vibration and sense of position. And anterior spinal artery, as I was telling you, anterior spinal artery, if it is lesion, it results in anterior myelopathy. There will be pain and temperature sensation loss without affecting the proprioception below the level of lesion. And this also results in spastic paralysis. So, after the stage of recovery, nowadays a lot of the development in medicine, in especially the rehabilitation program, the patient recovers. Otherwise, if the proper care is not taken, the patient enters into a stage of failure. In chronic spinal patients, due to lack of proper nutrition, repeated infection and toxemia occurs, and this results in failure. All reflex responses disappear, muscles become too flaccid, septicemia also may develop. Early use of antibiotic and glucocorticoid and especially nutrition and the rehabilitation program is very useful in this the patients with spinal cord injury. So to summarize, the effects of spinal injury depends on the site and extent of injury, the stage of spinal injury, whether it is in the acute stage, intermediate, or in the chronic stage. In acute stage, all reflexes and sensations are grossly depressed. In the intermediate stage, recovery happens. Not only there is recovery, they become hyperactive. But then in the later stage, there will be either full recovery or it may lead to failure. So spinal cord controls the basic reflexes for immediate motor activities and the postural changes. And the locomotion generator for basic movement is located in the spinal cord. Before I close my class, just a little joke actually. A student can say, what is this GKP? No. Definitely I will not say GKP here. Now, Gopal Krishna Bhatt. It is the greater knowledge in physiology. What I told you, this is the greater knowledge in physiology. But I will not disappoint you. This is GKP. And whatever I told you, this is all from the GK Pal's book. This is the Neurophysiology in the volume 2. But this book is sold in a huge number. And this is in high demand. Thank you so much. I really so grateful to your entire association for organizing such a wonderful program and making me part of that. Thank you, sir.
I know all our regions have benefited so much. The problem we face, the bowel and the bladder, the neuroplastic bladder circuit, then time of correct time, the stimulation of the neuropod, the spinal cord, the CPG, central pattern generator. Also, we are now trading with this repetitive transcranial magnetic stimulation. Everything is arranged so beautifully, all the syndromes. That is asked in a long question in your first paper. So, as sir is a great teacher, no doubt about it. Apart from a great orator. We have also, sir, so much, thank you so much, sir. So just a small felicitation from our association side. President, sir, please come forward. Respect and momentum to our beloved and visionary director.
Sir, please.
So a lot of credit to Anjali sir. He is working silently. So on behalf of IAPMR Association, our president,
Sir, please
our
सामने.
director sir. Sir, इधर आइए ना, दिखाई नहीं देगा.
It is a pleasure, sir.
I'm really so delighted to see Lord Jagannath. There is no better presentation than this.
I hope so.